Welcome everyone to our webinar, the Women's Caucus webinar, our third webinar in 2020. Today we're going to be talking about some additional critical issues in women's health, and we have two amazing speakers who will be sharing work that they are doing in the area of women's health. And before we get started, I just wanted to do a brief presentation on the Women's Caucus to familiarize those of you who aren't familiar with Women's Caucus. And I'll just start out by saying I'm Michelle Williams. I am the chair of the Women's Caucus. And the Women's Caucus is a component of the American Public Health Association. And our goal is to really be committed to discussing and bringing light to women's health issues that are often not discussed or that are, just something that's not in the mainstream. And that's why we try to hold these webinars so that we can make sure that we are speaking about women's health, beyond just the annual meeting. So that's the goal. And you can find more information about us on our different social media sites, and I'll put that information up in a bit. So our first speaker will be Manu Multani. She is currently a soon-to-be doctoral candidate at the California Institute of Integral Studies, studying anthropology and social change. She is focusing on sexual and reproductive health decision-making in Punjab, India. Manu is also a health education and research fellow in the Sahara, with Sahara, a nonprofit dedicated to serving survivors within the South Asian community of Los Angeles. She has a master's in global health and has worked in the public and private sectors for the last 10 years, including in Bolivia, Mexico, and South Africa, across the myriad of social determinants of health. She enjoys intellectual conversations, meeting people to understand their politics, and hiking with her partner and pup around their neighborhood in Los Angeles. Our second speaker will be Dr. Tiffany Green. She is an economist and population health scientist whose area of expertise is understanding the causes and consequences of racial, ethnic, and nativity disparities in reproductive health. She is currently an assistant professor of population health sciences and obstetrics and gynecology at the University of Wisconsin-Madison. Dr. Green earned her PhD in economics from the University of North Carolina at Chapel Hill with a BA in economics from Florida A&M University. Go Rattlers. Dr. Green's research has focused primarily on understanding the individual, family, and structural level determinants of disparities in health and maternal birth outcomes. She is particularly interested in understanding how and why Black women, regardless of nativity or socioeconomic status, experience the worst maternal and child health outcomes of any racial ethnic group, and what solutions might ameliorate these persistent gaps in health outcomes. Her work has been published widely in journals such as the American Journal of Public Health, the Journal of Women's Health, and Health Services Research. Her research has received funding from organizations such as the Foundation for Child Development and the National Institute for Healthcare Management. Most recently, she was selected as a member of the inaugural cohort of the Society of Family Planning's Changemakers in Family Planning as a University of Wisconsin-Madison School of Medicine and Public Health Centennial Scholar. So without further ado, we'll go ahead with our first speaker.
Thank you, Michelle. And also thank you for having me join the APHA Women's Caucus. This is really nice to be able to share this space with everyone amidst what's going on. So my name is Manu Multani. I'm currently a research fellow focusing on health education at an organization called Sahara, which is in Southern California. In Los Angeles. I'm also currently a PhD student in anthropology and social change. So this sort of project was a culmination of both of those roles sort of coming together. And so the objective of the presentation is to emphasize the importance of the role of community building in addressing health disparities, to really encourage the continuation of creative approaches to public health research targeting vulnerable, hard to reach populations through unique methodologies, and to share strategies for conducting a creative project within the constraints of COVID-19 and shelter in place. Michelle, is my audio okay? I just want to do an audio check real quick.
It is.
Great, thank you. So the approach to the project, I collaborated with staff members of Sahara, and as Michelle mentioned, it's a nonprofit providing culturally and linguistically specific social services across a gamut of issues. I've also have their 24-hour helpline information here on their website should you guys be interested in it. And the approach included assessing who would be able to really safely, technologically, and enthusiastically take part of the project. So people that we actually had access to, people that were participants in several services at Sahara, and that had already sound, reliable relationships with Sahara staff, because that was really pivotal in terms of working in this environment and doing such a project. And then we interviewed each participant after we developed the photos, and then I did a qualitative thematic analysis of the photos based on those interviews. So some of the things in terms of adapting our methodology with COVID-19 included, making sure that there was a particular point of collection and drop-off, which became the Sahara office, and really structuring that time accordingly so that we would minimize contact, providing instructions over the phone and clarity if that needed to be done when the disposable cameras were provided, and obtaining consent for engaging in this project, including a media release, because we'll be sharing these photos. And because we were adapting to shelter in place requirements and trying to keep safety in mind, it took about 3 months to finish the project. So some of the demographics include people that are survivors of domestic violence and shelter residents. Most were unemployed or have been unemployed due to the pandemic. And all the participants identify as women of South Asian descent. So one theme that came up often, and now I'll be sharing some of the photos from the actual project, and one of the themes that came up was cleaning, obviously, considering the time that we're in. But there were conversations with participants during the interviews that have shared sort of confusion on which hand sanitizer to use, but we're still constantly using it, always rethinking about what their cleaning routine should be, and really understanding how in-depth cleaning should be done. And there were also photos that were shared from participants who were wearing masks to show that they are adhering to shelter-in-place orders and protocols to keep themselves healthy even inside their home. And another thing that came up in regards to cleaning was also cleaning children's toys are now a priority, and how that's contributing to the anxiety and the approach to how to keep themselves safe. This photo shows a number of things. So when the shelter-in-place orders were sort of set, department stores had massive sales in some towns. And so because of that, people flocked to these department stores to get a lot of things. And this participant showed that they ended up getting luggage, and these suitcases were on sale during this time specifically, but they were hopeful that they were going to be able to travel again, go back to their homeland. And so they bought these suitcases in bulk because they were also on sale, which I thought was also interesting and hopeful. And then, everyone went to the grocery stores and bought as many groceries as possible. This participant also shared that that had a resulting effect of gaining weight. So that's why they took the picture of themselves on this scale. Another theme was constantly job searching online since the shelter-in-place orders. And if you couldn't have a job before and you weren't employed, it was also doubly difficult to secure unemployment, for example. So this theme of financially supporting yourself during this time was really common amongst most of the participants. The perception of empathy, I thought, was the most interesting, especially considering that there are a lot of anxieties on how to sort of behave in public and what are the exact protocols to follow. So these particular photos is a reflection from one participant sharing that they think that the perception of empathy has sort of gone to the wayside insofar as when it comes to being in public spaces and trying to get groceries or go shopping, and that the priority for senior citizens and people with disabilities are just not seen when they're out, and that more people are responding in a panic and anxiety based space versus actually being empathetic. Another common theme was sort of where and how to find joy and to participate in your own self-care. So there were a lot of themes around doing online workouts, walking in your neighborhood, being able to appreciate the beauty around you, and actually having the time to stop and think about the environment that is around you. And as you know, public health professionals, we know how important our built environment is to our health. And so this, I thought, was really beautiful to share. And there was a lot of appreciation for flowers, for growing plants, for gardening. And so those were also common themes. So housework also specifically took on a new meaning. I think for a lot of people, there was a lot of emphasis on actually taking pride in having a home, in cleaning our home, in being able to have a home. And so doing all of that was sort of their respite and their form of self-care. And, you know, doing the day-to-day activities seemed to be much more enjoyable because they were much more thoughtful and things that were taking up their day versus having to do things while simultaneously being part of the workforce. So I thought that was also an interesting way of reimagining your space at home. And there were plenty of hand washing photos. So this is a PSA to remember to wash your hands. And that's all. And now I will hand it over to Dr. Tiffany Green.
Okay. Can everyone hear me?
Yes.
Okay, good, because it's hard to say sometimes with the screen. Thank you so much for that great presentation, Manu. My work as a reproductive health researcher means that I spend quite a bit of time thinking about the role of prenatal care in women's health theoretically and empirically. And things became a lot more real when I became pregnant with my first child. And I was fortunate enough to have an obstetrician that I adored. But sometimes it would take a good bit of my morning or my day just going to prenatal care. And I thought about the fact that if I'd had to take the bus or had a less flexible job, I might not have shown up every time. And that caused me to think a lot more about how one's lived experience can inform the data that we analyze. And after I gave birth to my first child, I started working on this particular line of research, trying to better understand how Black and/or Latinx women access prenatal care, and more important, what their experience might be in these visits. So thank you very much to Dr. Williams for inviting me to speak today about a really important aspect of women's health here, the prenatal care encounter. Over the next few minutes, I'll talk briefly about my work on the drivers of Black, white, and Latinx white disparities in access to prenatal care, as well as those of other groups. What I'll do is I'll give you a brief overview of the prenatal care landscape, and then talk about my own work that uses nationally representative survey data from the early childhood longitudinal study birth cohort to empirically analyze the primary correlates of racial ethnic disparities in prenatal care use and content. And as such is a complement to the prior work in the sense that I do primarily empirical work. And I think that qualitative work is a really important component of understanding women's health more generally when we talk about how people experience care and experience life in challenging times. Before I go any further, I want to be very clear about something. We know that the birthing population just does not consist of women. We also have trans and gender non-conforming folks as well as part of this population. But the limitations of the data that I have and that I use unfortunately limit me to speaking about women alone. And I'd be happy to talk more about this in the Q&A. So let's get to prenatal care. When we talk about prenatal care is one of the most common forms of preventive health care that we use in the United States, and it's a key form of reproductive health care. It is an important chance to detect and monitor risky conditions, and it can be an important mechanism for improving maternal health. And we know that delayed prenatal care is associated with higher rates of severe maternal morbidity, mortality, and birth outcomes as well. When we think about racial disparity and ethnic disparities in prenatal care, it falls along the lines that we might expect. Specifically, among the highest adopters of first trimester prenatal care use happen to be non-Hispanic white and non-Hispanic and Asian folks. I want to also clarify here that I didn't in the beginning, that of course Hispanic people can range from white Hispanics, Black Hispanics, and others. Here we're talking about ethnicity. So non-Hispanic Black folks have among the lowest rates of first trimester prenatal care adoption, which is an important metric from the American College of Obstetrics and Gynecology in terms of making sure that maternal and child health outcomes are best, right? And we also know that Blacks and Hispanics are also more likely to have, not likely to have inadequate care. So the impacts of prenatal care aren't as simple as I've made them out to be. What we know is that the impacts of prenatal care have been controversial. When prenatal care was originated back in the early 1900s, John William Ballantyne, a Scottish physician, implemented prenatal care as a way to prevent fetal abnormalities. And he later realized that prenatal care might be able to prevent maternal, fetal, and neonatal deaths. But it's important to note that from the beginning, this was really about concerns about things like eclampsia and toxemia that drove the content of the visits. And as time goes on, many researchers started studying prenatal care more in depth. Some found that this was linked to better birth outcomes, and others didn't really find any effects. But when prenatal care really rose to prominence was in the 80s. In 1985, the Institute of Medicine implemented a really foundational and groundbreaking report that linked prenatal care to decreased incidence of low birth weight. Now, they said a few more things that were more complicated than that, but Congress really ran with that. And in something that would be pretty much unimaginable today, there was this wide bipartisan consensus that drove Congress to ask the states, or mandate the states, provide prenatal care to low-income women by raising income limits beyond what normally they would be with Medicaid. And this was great, except the fact that prenatal care increased, uptake increased, particularly among Black women, but there was very little evidence that it actually did what it was intended to do, which was improve low birth weight. And from that, people decided that, well, prenatal care doesn't work. And we can talk about why these things happened, but a lot of people incorrectly concluded that prenatal care didn't work. And that was premature. What we're finding, and what other folks have found, is that prenatal care is actually very important for maternal health. While it doesn't necessarily link very tightly to birth outcomes, we know that when we address these issues of causality, we know prenatal care is associated with better postpartum health, such as decreased risk of insufficient weight gain, lower risk of prenatal smoking, and longer birth intervals. And so I think that prenatal care in that sense, while the jury's still out in some ways about a broad effect on infant health, I think it's an important role to play in women's health. So one thing that got me thinking is, well, we see these disparities in prenatal care use. So why do we see them? And the first thing to think about is there are a lot of factors that impact use of prenatal care. We know the obvious suspects are things like income and insurance, where women get care. Do they have the transportation to get care? The challenging part is that the contribution of these factors, they're not relatively obvious. In other words, if we're doing simple regression analysis, that doesn't tell us to what extent each of these factors drives gaps. For example, you might think, well, insurance might be important and it's correlated with prenatal care use, but it doesn't mean that insurance gaps are necessarily driving racial gaps in those outcomes. The challenge for us here is that few data sources contain information on variables that we might think are important. Things that I talked about, like transportation, things like income. Those don't necessarily appear in the vital statistics birth records, and that makes it challenging to pinpoint from a policy and intervention perspective where we need to go to help close these racial and ethnic disparities in prenatal care. And so when I wrote this paper, I really wanted to think about how we might use data to quantify these characteristics. And so this paper is really looking about what the contribution of individual, household, and area level factors are to disparities in prenatal care use among non-Hispanic white, non-Hispanic Black, and Hispanic mothers. The data that I use are the Early Childhood Longitudinal Study. It's a birth cohort founded in 2001 that's a nationally representative sample of births followed from birth to kindergarten. And most important for our purposes, it contains lots of data on prenatal care use, and as well as maternal characteristics. I also was able to add county level characteristics because we think that neighborhood and policy environments might also drive prenatal care use. Things like the concentration of obstetricians, for example, might also impact racial disparities in prenatal care. So here we have prenatal care initiation in the sample. And again, these data are older, but what's striking is that the gaps in prenatal care use look pretty similar across time. And we see large gaps in prenatal care use, particularly between non-Hispanic white and Black mothers, but also between Hispanic and white mothers. Similarly, prenatal care adequacy, or going to care during the first trimester and having a sufficient number of visits, calibrated on gestational age is also important when we're talking about this issue. As I said before, there are a number of factors that affect prenatal care use, and I broke them down into these categories. Now, we can argue about whether these categories are arbitrary or not, but I made the decision to look at these particular factors based on the literature and the way that I saw these variables grouping together, specifically looking at issues such as maternal health and pregnancy-related factors, preconception behaviors as a marker for preferences, insurance, prenatal care location, socioeconomic status, and geographic characteristics. I'm happy to go through in more detail at the end, but I'll just provide an example to help you see what I'm talking about. Now, we know insurance coverage is likely linked to prenatal care use, and as you can see, there are very large gaps in this sample and in other national data showing you that about 2/3 of Black women had their births covered by Medicaid compared to less than 25% among white women. So the idea here is to look and see whether these gaps in insurance coverage and other factors are driving prenatal care use. Similarly, we see that, that receiving care in public clinics is much more prevalent among Black and Hispanic mothers relative to white mothers. And we might think that the location of care also influences your desire to go to care, depending on whether the staff behave in certain ways in certain kinds of clinics. And we can also see a similar story when it comes to socioeconomic characteristics. Marital status is a proxy, maybe not the best one, for different kinds of social support. And white mothers are more likely to be married and are more likely to be educated relative to other mothers. So what does this all boil down to? What I use is a form of regression decomposition analysis that I won't go too deeply into, but this allows us to measure the contributions of individual variables or categories to disparities in outcomes. For example, we might look at the contribution of maternal characteristics, or SES, to these gaps in outcomes. It's called Fairly Decomposition, which is based on Oaxaca blinder decomposition. And I feel obligated to mention that a woman statistician, Kirigawa, was the really foundational work in this area, but is not often acknowledged. But so what do we have? What are the factors that really determine these gaps in first trimester care? Well, maternal health and pregnancy characteristics that could include things like age were significant. Preconception health behaviors that I tried to use as a proxy for preferences, not really significant. Here, unsurprisingly, socioeconomic status mattered quite a bit. About half of these disparities seem to be associated with SES, including income, education, and other characteristics. I'll get into the breakdown a little bit more later. Similarly, insurance coverage matters in terms of going to care, and this is not surprising. In a lot of states, it's hard to sign up for Medicaid, and you are delayed and likely more limited in the providers that you can see. So it's not surprising that differences in insurance explain part of these gaps. The location of prenatal care mattered a little bit, and the socioeconomic and healthcare environments didn't matter much in terms of statistical significance. Keep these results in mind when we look at the adequacy of prenatal care. So the adequacy of prenatal care is not only going to care early, but also that you have a sufficient number of visits. Maternal health and pregnancy characteristics, they don't matter here, neither the preconception health behaviors. But socioeconomic status was really even more explanatory here. So not only does SES matter for initiating care, it matters for whether you keep going to care. Insurance coverage, again, it matters for you getting there, but not continuing to go. The location of prenatal care also matters. Are you going to a public health clinic versus a private clinic? So people that were going to private clinics, that seemed to affect that gap more. So what does this all mean? I'm happy to show you the regression results, but what it means is that when we talk about SES, the provision of support beyond income is really critical. For example, I found that education mattered a lot for whether you actually initiated care in the first place, but what mattered more for whether you kept going to care was being in a household that has a car. right? Those things are really important when we think about interventions. So we care about pregnant people going to care early. You know, there's one set of interventions, potential interventions, keeping in mind this is not causal. But if we care about them continuing to go, we need to be thinking about whether they have the means to get there. Also, WIC mattered. So WIC didn't matter so much for initiating care, but in terms of having adequate care, it really did matter. So thinking about social programs and their ability to help influence whether pregnant people are getting the care that they need. Similarly, location of care really mattered for the adequacy of care. And that is women that weren't going to private care or were getting care in public health clinics did not get as much adequate care. And this is not surprising that it's explained the gaps. There have been lots of, a little bit of research looking at Black and or Latinx populations and talking about the poor experiences they may have in these public health clinics in terms of being respected by staff and really making sure that they have the experience that they need. And finally, again, as I said before, insurance and pregnancy characteristics such as age and having a prior preterm birth, that matters, but only when it comes to the initiation of care. And so the end story here is, again, that the things that get you in the door aren't the things that necessarily keep you coming in terms of interventions. Again, not a causal model, but a really good place to start when we're thinking about randomizing interventions and really seeing what works in a causal framework. So what's the missing factor? Well, you know, these models seem to explain a lot of the variation in racial disparities in prenatal care use, but not all of it. So we need more information about attitudes and resources. Again, things like we can't capture, like discrimination and unfair treatment that has been shown to affect prenatal care use. That needs to be in these models, but it often is not collected in these data. What about other resources that allow women and other pregnant people to go to care? These models had a lot of that, but not more. And I think that's important to collect when we're talking about this. Another challenge is I'm talking about prenatal care, but I think the continuum of care matters when we're talking about women's health. That is not just prenatal care, but intrapartum care. What are you doing between pregnancies? And preconception care also might be critical, although I actually am critical of preconception care, and we can talk about that. But I think in a larger sense, it's critical for us to be providing reproductive health care for reproductive age people in general, and not be worried about necessarily whether they're getting pregnant or not. We need to be treating women and other folks and not be worried about whether they're going to have children and essentializing them in those ways. And then, you know, information about quality and content. We don't have a lot of information about what actually goes on in the prenatal care visits. And that's also very critical and crucial. And I was able to get at that a little bit with these same data when I looked at content differences. So I wanted to understand whether there were racial ethnic differences in the content of prenatal care use. As a former pregnant person, I remember that everybody became a doctor once I got pregnant. They asked me about what I was eating, touched my belly, you know, lecture, what are you drinking coffee? Are you doing these things? And that's a common thing for a lot of pregnant women. But when we think about what actually goes on in the care visit, we have less information. In this particular paper, I and my co-authors wanted to know a little bit more about these differences across US-born and immigrant mothers. And the long story short is we didn't find many differences across immigrant mothers, but we did find differences by race ethnicity, which I'll talk about in a second. Using the same data, the ECLSB data, we looked at a number of questions. They asked the women in the survey whether they had gotten information on diet, which is of course linked to weight gain recommendations, whether their doctor had discussed drinking, smoking, breastfeeding, infant feeding, child development, safe medication use, and then there was also some information, I think, on preterm birth. So we did simple logistic regression analysis that, again, I'm happy to send you the paper if that's of interest. But we found that Black women were really more likely to report receiving specific counseling on everything. They're more likely than white women to discuss smoking, drinking, breastfeeding, all of those things. And the idea is that providers may have emphasized counseling because they thought Black women were more at risk. I'll get to whether that was valid in a second. We also saw that Hispanic women were more likely to report discussing certain topics like smoking and drinking. Why I found this odd was that smoking rates among Hispanic mothers were among the lowest of all mothers in the sample, and we see this with national data. Similarly, Black women are less likely to smoke than white women. So I found it really interesting that doctors chose to have those conversations with Black and Hispanic women, at least from their self-report, and it's really white women that are more likely to smoke than both of those groups. Sorry about that. And then I found a result that was somewhat puzzling. We found that Asian mothers were less likely to report discussing safe medication use. And we puzzled over that quite a bit. And the reasons were quite unclear. The little data that's out there suggests that over-the-counter medication use is similar across white, Black, and Asian women. So we thought this result definitely needs to be replicated in other data, because that we found quite puzzling. The challenges, of course, it's unclear from the data whether this content was concordant with guidelines. There's not only the discussion that you have, but when you're supposed to have it, and what you discussed about diet and smoking, for example. And then, of course, there are the limitations of self-report. I think ideally we want to be able to triangulate some of these self-reported data with medical records to get a fuller picture of what's going on. And then the mechanisms are unclear. Why, and other people have found this as well, why do we still see these racial ethnic disparities, even if we control for maternal characteristics? And I think understanding these underlying mechanisms are really important, and particularly when it comes to our national conversations about bias in communication, et cetera. So that's something that I'm hoping to push forward in my work as I move on. I'll end here with a couple of recommendations for moving the work on prenatal care as it relates to women's health forward. The first research gap, I think, is really identifying the most effective reproductive care content and delivery methods. We don't quite know.
Good, how are you doing?
We haven't really assessed prenatal care quality and outcomes the way that we should in a standard way. And I think being able to link those to birth outcomes is very important, and maternal health outcomes. The second gap, and I think we need to assess the degree to which discrimination matters for pregnant people's prenatal care use and postpartum care use. And I think we need to really commit to sharing and linking data across sectors. And that means administrative data, survey data, and integrating it with qualitative data to have a much fuller picture of what pregnant people's experience is like in the prenatal care encounter. I think in that way, we can make more effective policies and make more effective interventions that will improve the disparities that we're seeing. And I think at the end of the day, though, I'm talking about prenatal care, but I think we need to go beyond prenatal care to understand in a holistic way that women and other gender nonconforming and trans folks deserve care throughout the life course. And that if we do this in this way, we can see our children grow up and become their very best selves because we've invested in their care. That's it from me. Thank you.
Awesome. Thank you both so very much. So before we get into question and answers, I just wanted to share a couple of important announcements because I know sometimes people need to get off a little bit early. So in regards to for this webinar, we will be providing some CEUs if you're interested in that. So all of the participants will receive an email from me after this webinar containing a link to an evaluation form. So if you would like to claim some CEs for participating in this particular activity, you can just complete that form and we'll get that information over to you. And that's sponsored by my wonderful university, George Mason University Department of Global and Community Health. And then also please note that the recording of this webinar will be available on our website, as well as I will send a link out to all the participants. And I will ask the author or the presenters if they're willing to share their slides. And if so, I'll also send those out via email. So now we can go ahead and get into some question and answers. So I'll start with one question that was put in the chat box. And for those of you who would like to answer or ask a question, feel free to unmute yourself and then ask the question. And but if you don't want to, you can also put that in the chat box and I will ask the presenter. So Dr. Green, you were asked a question, and the question is, why are you critical of preconception care? In what way?
I realized when I said that I was going to start something, but here we are. So I'll start with two things. One, I would highly recommend the work of Miranda Waggoner. She's a sociologist, I think she's at Florida State, who writes about, the origins of preconception care. And there's two issues. One is this idea that Miranda talks about, this idea of assumptive motherhood. What does it mean when we treat women as assumptive mothers? Well, you shouldn't drink during pregnancy. Oh, okay. Well, you shouldn't drink because you think you might be pregnant. And, you don't know if you'll get pregnant. So, you shouldn't drink because you could be doing something horrible for your child. And we don't talk to cisgender men that way, right? It's the whole idea that throughout our reproductive cycles, we are presumptively pregnant and we're treated that way. And I think that's problematic on a number of dimensions. But as an economist, I'm also interested in causality, right? And so that we would have a different conversation is whether preconception care is causally related to better birth outcomes. And my assessment of the existing literature in terms of what we have is that we don't have good evidence that preconception care is actually linked to better maternal and child health outcomes. So we have challenges from both an ethical perspective and we have issues from both a causality perspective. And that doesn't mean that I don't think that women and other folks should not get care. It just means that the way that we have packaged it, I understand that there were lots of reasons why very well-intentioned folks were trying to promote women's health. But I do not think that the primary mechanism for improving birth outcomes is treating all women as presumptively pregnant.
All right, thank you for that. And we have another question for you, Dr. Green. The question is, what are the cultural influences in access to prenatal care? And the person who asked this question says, I know Asian Indians have a huge family network of care and advice that they trust.
So that's a good question. I'll say first that as I said before, I'm an empiricist. And I think these are some of the things that can be better answered with approaches that Manu takes, for example, using qualitative data. Cultural influences always are a very tricky thing for me because they can always be weaponized. As a Black scholar, I see very clearly the way culture is weaponized to talk about deficiencies in people's healthcare use and behaviors, when we can look at structural factors that are driving these outcomes, such as the lack of health insurance, such as poverty, such as all those things. So I would say I can certainly see how a network of trusted folks would influence who your care provider was. As for my part, I can tell you that personally, I looked specifically for a Black obstetrician who would understand some of the challenges that I was going through during pregnancy. Right, and I know other friends from other cultural groups, immigrant groups, have picked providers based on that as well. So my long story short, I think that perhaps networks matter, but culture is something that I don't necessarily feel comfortable talking with when it comes to health-seeking behaviors. Maybe other people might have different perspectives.
Thank you. Other questions from our attendees? Again, you can mute yourself or type it into the chat.
I received a question privately, and I think it's important to talk about too. So one of the photos had the Ross department store logo, and a participant from the webinar was asking what ethical considerations should be made when reporting data on unfavorable behavior happening in the community. And I thought that was a really good question. And I'm really thankful that this participant shared that, because I think we do have a ethical consideration to make as we strategize and communicating on what's actually happening from the perspective of our clientele, and how that clashes with social, I guess, images of, you know, department stores and what that means. And when I do share the PowerPoint, I will make sure to blur that. But I also think that it is a little bit of a gray area, because it is from the perspective of the individual, and you want to portray that perspective as honestly and as authentically as possible. And that goes not just with, you know, putting on blast a Ross department store, but I think that's also has to go with other stories and how their interactions are with other places. So yeah.
Excellent. Thank you for bringing that to our attention. Do we have other questions from our audience members, our attendees? Okay, Dr. Green, I have a quick question for you. So I know some of the work that I'm doing is in regards to trying to increase the use of telehealth. Do you think there's value in telehealth for preconception care?
I do. So I'll start by saying that my students at my former institution, who I miss very much, my undergrads, they came up with some really innovative prototyping for an app for Latinx moms. Trying to that would be in Spanish and in English, and would speak to some of their concerns during care. So this is about prenatal care. I think that telehealth can be a really useful thing, particularly if it's resonant with the group that we're talking about. I think some of the challenges are that everybody doesn't necessarily have phones with heavy data plans, and they might not have the capacity to use telehealth if they don't have phone services that facilitate that. So I think the telehealth could be very important, but I'll leave it up to the experts to say that. But I do think we need to really think about inequality and how it might manifest in who has access to the data use and the technology to be able to access it.
Okay, awesome.
And Manu, I have a question for you in regards to using Photovoice, because I too am a qualitative researcher, so I appreciate that type of research methodology. And I was wondering, had you and your colleagues thought about trying to use this to look at the experiences of someone who is dealing with COVID, either from a personal perspective of being infected or from like a caregiver perspective?
That's an excellent way to approach it too, as another project. But yeah, I mean, you know, talking about ethical considerations too, and sort of seeing how that could be honestly and accurately portrayed without compromising one's identity, I think would certainly be a question. But if it's, you know, one of the things that we emphasized when we shared the disposable cameras were, you know, these like, don't photograph children. And also if you photograph yourself, we're going to automatically assume that it's okay to share your photograph, and that's sort of implicit consent. But yeah, so if you can navigate around that, I would think that that's sort of the major hurdle and challenge as an organization to publicize that information that you get or that research that you gather. But that would be really interesting.
Okay. And then we just had two questions pop up in the chat box. And Manu, since you're on, I'm going to ask you the question that came up for you. A participant asked, what impact in the long term, 2-year and 5-year, would you hope this project will have?
I haven't really thought of it in that way. I think it's a very time specific, and please let's not be in the COVID world in 2 years or 5 years. But, you know, I think it's also interesting if you were to do a post-COVID world retrospective sort of analysis and seeing what it looks like and approaching it that way. I'm sure there are people that have done Photovoice over a time period, especially as it relates to people aging and how that like documents their journey. So I'm sure there's projects out there that have done that over time.
Thank you. And Dr. Green, a question came in for you from one of our awesome Women's Caucus members. Dr. Green, can you describe what are the critical aspects of prenatal care for Black women, given the structural factors that Black women face?
So you might hear my little ones in the background, so just ignore that. But this is a really good question, and I spent a lot of time thinking about that. I would answer it in this way. First, I think we need to think beyond healthcare and think about, as you pointed out, the key structural factors that likely influence outcomes. We know that healthcare is an important but small component of having better health. And so I think the best work now is really trying to look at the structural factors that affect health, like poverty, looking at domestic violence, looking at those housing instability. Being able to connect women with those factors is really important in terms of care. So I think we are seeing innovative new models. I don't think I'm at liberty to say all that what's going on here, but there are some folks here working on some really exciting stuff, being able to integrate these social determinants with the prenatal care visit. And I think that's going to be really critical for Black women. Another thing that we don't talk about as much that I think is really important is mental health. Poverty, the stress from racial discrimination, we know that they adversely affect mental health. And so I think addressing those issues is critical, and making sure that women have, and other pregnant people have health care surrounding mental health during pregnancy is already critical. We see that elevated rates of prenatal and postpartum depressive symptoms among Black women, and not just Black women, but Asian women. Right, and I think addressing those, particularly among the latter that gets ignored, is a really important thing. So long story short, integrating prenatal care with social determinants and social services that allow Black women and other women of color to get their needs met, and also addressing mental health issues that arise in part from these structural factors, and making sure they have access to those services.
Awesome, awesome. And so I see a statement, and I'm not sure that this is a question, but it says, please share how those authors of studies into how domestic violence affects health. Maybe it's more of a statement, or do you have something to respond to that, Dr. Green?
Yeah, I'm not sure exactly what please share the authors of studies into how domestic violence. Are you looking for studies about domestic violence and health? Is that what?
Or perhaps,
yes. So I'm happy to. I think if that was is that what they're looking for? Sorry. If you'd like me to send you some studies offline, I'm happy to do that. If you'd like me to send me an email, I'm happy to share some studies with you. I think that's what Marilyn's asking. Okay.
Yeah. Okay, perfect. All right, so we're right at the end of our time. So I wanted to share a couple last things before we sign off. And I have to apologize profusely because I promised Dr. Green that we would have closed captioning, and it started and then an error message popped up. So I apologize. I don't know what happened, but the video that I share of this recording will definitely be closed captioned. And again, I apologize for that not happening. Some error occurred, and I apologize for that. But please make sure, if you're interested in more webinars from the Women's Caucus, feel free to check us out on our different social media channels, our website, which is currently being updated. So it does not have a lot of information right now, but our website will contain information about the Women's Caucus. And if you ever have any ideas for webinars, or even if you're someone who wants to share the work that you do, and it does not have to necessarily be research, it can be practice or anything related to women's health issues, feel free to contact me, and I'm more than happy to schedule a webinar to feature work that's related to women's health issues. So thank you all so much for attending. Again, be on the lookout for emails from me containing the link to the presentation, as well as a link to the evaluation if you are interested in getting continuing education units. I want to say thank you again to our awesome speakers. I really do appreciate you taking the time. And Dr. Green has a birthday today for one of her little babies. So thank you so much for taking time on the special day to be here with us. So we really appreciate that. Thank you both.
Thank you.
Thank you. Nice to meet you.